Good morning, good afternoon, or good evening, depending on your time zone. I welcome you, our global audience, to session number 10, Health Systems, Quality of Care, and Equity for Women and Children in Low and Middle Income Countries. My name is Imrana Malik, and I will be your moderator for this session. I'm a critical care physician at MD Anderson Cancer Center in Houston, Texas, in the United States, with an interest in sepsis in cancer patients. I'm also a member of the executive committee of the GSA. Before we begin, a quick thank you to our Congress sponsors, bioMérieux, Menarini Group, Sobi. We're very grateful for the support. Today, in our session number 10, we have 5 excellent speakers, and we will have time for approximately 1 to 2 questions after each talk. So now it is my privilege to introduce our keynote speaker for this session, Dr. Zulfiqar Bhutta. Dr. Bhutta is a distinguished university professor and the founding director of the Institute for Global Health and Development and the Center for Excellence in Women and Child Health at the Aga Khan University in Pakistan. He also holds the Robert Harding Inaugural Chair in Global Health Child at the Hospital for Sick Children in Toronto, as well as the co-directorship of the Sick Kids Center for the Global Health Child. He leads large research groups globally with a special interest in research synthesis, scaling up evidence-based interventions in community settings, and implementation research in fragile health systems. He has been ranked among the top cited researchers globally since 2013, and most recently he received the 2022 John Dirks Canada Gardner Global Health Award and the 2025 Virchow Science Prize. Dr. Bhutta's presentation today is titled Antimicrobial Resistance and Neonatal Sepsis, Pragmatic Solutions for Low and Middle Income Countries. Welcome, Dr. Bhutta.
Thank you very much, Dr. Malik, and I'm very honored that the organizers asked me to participate in this sepsis session. In the interest of time, I'm going to be relatively brief. I'm going to be talking largely in the context of newborn deaths. And to many people in the audience, you may or may not know that while we have made major strides globally in reducing child deaths from about 12 million deaths in around 1990 to less than 5 million deaths at the moment, progress comparatively in reducing newborn deaths, which is deaths within the first 28 days of life, has remained variable and has also been slower. So we're still talking about 2.3 million deaths amongst newborn infants, which are potentially preventable annually across the world. And these deaths are largely clustered in low and middle income countries. So if you look at the disparities in newborn mortality across various regions, as per the most recent interagency report on child mortality, this disparity and its clustering in many low and middle income geographies becomes very apparent. And it's also very clear when you look at the differences in mortality due to neonatal sepsis. And these differences between high and low income countries is stark in terms of both the prevalence and also the outcomes, clinical outcomes. And you can see this very strikingly as to how, despite the fact that we have reduced mortality somewhat, if you look at low-income countries in contrast to high-income countries, you are looking at differences which are several magnitudes higher in terms of survival rates. And this can be clearly seen also geographically, as I've mentioned, in many low and middle income countries, particularly in sub-Saharan Africa and South Asia. Now, what has changed in the last decade and a half is that the spectrum of where we are seeing these neonatal deaths has also changed. In the year 2004, when we first looked at this in the context of global newborn mortality, much of the mortality was clustered in women who were delivering in domiciliary settings at home. And the focus was therefore largely on community-based practice and primary care. As we speak now, there has been a global shift, and a large proportion of these deaths occur amongst babies in primary care settings, but also in hospitals, because much of the deliveries, about 80 to 90% of the births, are now in facilities. There is increasing load of neonatal admissions to secondary care facilities, and also the quality of care in many of those facilities is also variable. Now, there has been admitted interest in healthcare-associated infections in newborn. They used to be called nosocomial infections, and the evidence base around this has also grown steadily with a number of interventions that we look at, both in terms of skin care, the use of appropriate diagnostics, and also ancillary support strategies to reduce the adverse outcome in many of these hospitalized children. You will notice that there is also evidence growing on how you can, as part of clinical procedures, reduce the propensity for infections in many of these hospital settings using particular devices that we use, whether they are peripheral lines or central lines. So if you look at the evidence that is there, largely, as you will notice from low upper middle income countries, there is a fair amount of evidence that preventive strategies to reduce hospital-acquired infections, healthcare-associated infections, work. And they also are possible to bundle with other prevention strategies and care strategies for small and sick newborns. Now, as part of this trolling of the evidence that our group has been doing in the last several years as a contribution to the Lancet Newborn series that's coming out later this year, we also looked at the relative contribution of antimicrobial resistance. Here are data from my own center at Aga Khan University that we have prospectively collected over the last several decades. And if you notice, for many of the common pathogens that you see causing neonatal sepsis amongst both community-acquired and hospital-acquired infections, the relative odds of dying for newborns associated with drug-resistant infections range from about 2 to 5 folds. And that is quite significantly notable in many large data sets as a relative contribution of antimicrobial resistance. You put this in the context of global evidence around AMR, and it becomes very striking that we are dealing with a large number of mortalities across the spectrum of newborns, children, and adults. And cumulatively, it has been estimated by IHME, Mohsen Nagawi, my colleague who's been looking at this, that between 2025 and 50, project this for the next 50, 25 years or so, we would be looking at hundreds of millions of deaths associated with antimicrobial resistance. And it has a huge economic burden. If you look at what it will cost us, this is ranging into the kinds of economic costs that you get by extreme economic disruption. And it will potentially force a number of people who live in LMICs and are therefore required to take expensive antibiotics into poverty. So in a comparative assessment, before I get into the nitty-gritty of strategies to reduce this, if you look at the global burden of mortality and DALYs associated with antimicrobial resistance by age groups, you can see at the bottom how important this is for neonatal mortality. And these data have been published pretty recently in terms of global estimates and contribution of AMR to neonatal survival and disability over time. So we've recently published an in-depth analysis over the last 3-4 years of what are the strategies that can reduce both the burden of antimicrobial resistance and also improve outcomes related to antimicrobial resistance. This systematic review was published in The Lancet a couple of months ago, and we largely focused on evidence from low and middle income countries from both facility and community settings. So I will leave it for you to study the paper in detail, but this, in terms of its inclusion criteria, the systematic review looked at both term and preterm infants receiving either kind of care, any intervention policy or strategy designed to promote antimicrobial stewardship, to mitigate the development and spread of antimicrobial resistance, and controls were standard practice or no interventions. And we looked at a range of outcomes that I've already alluded to: bloodstream infections, CLABSI, sepsis, early or late localized infections, and also looked at a number of secondary outcomes, including antibiotic use overall. We looked at a large amount of information from a range of studies, but by and large, I think 26 studies or so qualified as being supportive of this evidence review from a range of geographies, and you can see them outlined here, and also on this map. Much of this evidence comes from Latin America, parts of Africa. I wouldn't say sub-Saharan Africa in particular, but a reasonably large number of studies from South Asia and China. The interventions that we looked at were broadly classified into three categories: those that required regulation, those that required education, and those that required restriction. So these are largely focused on practice-related interventions. For example, reduced or delayed initiation of second-line, third-line antibiotics, or shortened duration of antibiotic therapy. And these are classified into both single and multi-component. And as you can see, there is a fairly large number of multi-component interventions, which included two or more of these interventions. You will note that 11 studies had looked at a combination of regulation, education, and optimization. So by and large, we felt that this was a reasonable amount of information to synthesize. And you can see in terms of its distribution as to how it is laid out in the context of strategies for newborn care. A large proportion of these studies looked at training sessions, audits, and also empirical strategies to reduce duration and controls second and third line antibiotics. What did we find? First of all, the good news is that we found that there were a range of these strategies that, when combined in terms of a meta-analysis, seem to have an impact on outcomes. And if you take optimization as one set of strategies, both culture-proven sepsis and the use of antibiotics in newborns could be significantly reduced. And well, some of these studies were heterogeneous. I think this is reasonably strong evidence that this is an approach that needs to be tested at scale and probably taken forward in health systems. But what about multi-component interventions that I've just spoken to you about? If you look at these multi-component interventions, the evidence becomes even stronger because we have a larger number of studies. And here, all-cause neonatal mortality could be reduced by as high as 27%, and also multi-drug resistant organisms, colonization or sepsis, receipt of antibiotics, and also receiving antibiotics for longer. So no question that the literature from low and middle income countries around multi-component interventions to reduce antibiotic use and also choice are very promising. And this requires us also to look at what are the potential barriers in terms of implementation that we could encounter in trying to see how these could be scaled up within health systems. So there are a number of health system building block implementation barriers, which range from infrastructure, supply chain issues, microbiology support, training and quality of health workforce, but most importantly, also health information systems. We found that the barrier to implementation in many of these strategies outside of research context related to lack of data. And if you don't have data on monitoring and on prevalence of various drug-resistant infections, you're probably groping in the dark. But we could overall conclude from this work that these were very promising interventions that now needed to be integrated within strategies for health systems interventions to improve newborn care outcomes. So far, WHO has largely focused on just the use of antibiotics, the availability of antibiotics, and they are scaling up in strategies to look at presumed newborn sepsis. There has been very limited guidance, which has led to change in practice in neonatal care units or obstetric care units around what we need to do to reduce antimicrobial resistance. And I think it's now time to tailor-make local strategies, which include all of these three critical interdependent components of regulation, education, and optimization. Supporting laboratory growth to be able to diagnose and also look at sensitivity patterns, even if it's distribution and not more sophisticated measures. I think molecular biology methods now make it easier for people to see it in many contexts. And also approaches to implementation, which will look at collaborative networks or where these need to be implemented at scale. I can tell you, just in terms of our estimation of what referral facility-related deaths due to antimicrobial resistance could be averted globally, we are talking about upwards of 20,000 deaths that could be prevented related to antimicrobial resistance in newborn infants just by implementation of these at scale. So I'd like to finish by acknowledging the large group of people who contributed to this work, not just within my own team at SickKids, but also a collaborative technical advisory group representing several organizations that you see over here from both low-income countries and also North America. So thank you very much for your attention. And if there's time, I'd be very happy to answer questions.
Thank you so much, Dr. Bhutta, for that excellent start to our session and the discussion on antimicrobial resistance in neonatal sepsis. Really appreciate how you took us from this kind of global view of what's happening and try to distill it down to what are some very key components that could really change what this timeline and what the outcomes look like. I'm looking at our chat and we have excellent representation from around the globe. We've got listeners from the US, UAE, Indonesia, North Macedonia as well. And in terms of questions, maybe I'll start here. In terms of what you've shared for the initiatives, which one do you feel is like the main initiative that can have the biggest impact in driving and decreasing AMR in neonatal populations? We know we have multiple initiatives, but are there ones where you can highlight and say, these ones you definitely need to have engaged and initiated?
So the bulk, Dr. Malik, is related to healthcare-associated infections, where we see a lot more antimicrobial resistance associated adverse outcomes. So we think very clearly that in the bundle of hospital management of newborns and mothers, that these strategies of optimization, regulation, oversight, and importantly, education, can be readily implemented as we speak. And they should be part of, just as we teach people how to handle newborns and how to provide basic care support, thermoregulation, looking after their respiratory health, as well as the cardiovascular system. These things should be very rapidly become protocols that are implemented both by medical staff, nursing staff, as well as associated ancillary staff in many of these facilities. These babies undergo procedures. We have often found that those procedures are not universally applied by every kind of worker who's there. So these can be implemented and scaled up as bundles of care that you can implement in health systems. And it's, I think, appropriate time to do so, even though our universe of studies that have been done to show impact for this is relatively limited. But this is a growing problem and it's not going to go away. And if we start now, we will have some hope of both regulating the existing burden, but also prevent future burden of antimicrobial resistance, which is only going to grow.
Absolutely. Excellent. Thank you so much for that response. I have a quick second question, if you don't mind. Do you find that there's any difference between term and preterm infants and infections and with the resistant organisms?
Well, the burden differs just because of the nature of procedures and interventions that we have in preterm infants, which are generally much greater than term infants. Term infants generally end up in hospital units because of either, things like pulmonary maladaptation or minor issues or some congenital malformations, typically do not stay in for very long. But preterm infants are in hospital situations for a very long period of time. And therefore, just the nature of intervention for preterm babies is different, both in terms of numbers, quantum, and who does it. I did my first study of looking at healthcare improvement using mothers as nursing support for newborn babies way back in 1992. I mean, that was published in the BMJ at that time as to how creating a mother-baby unit and reducing congestion and overcrowding in neonatal support units by creating that environment by itself reduced the burden of infections quite enormously. So simple things, reducing overcrowding, overseeing procedures, ensuring hand washing, use of sanitizers, these are things that can potentially reduce both the burden and also the likelihood of spread of highly multi-drug resistant organisms in this kind of setting.
Thank you so much. Definitely appreciate your presentation. And now we will move on to our second speaker. I'm very honored to introduce Dr. Angela Caswell. Dr. Caswell is a professor of healthcare studies and currently serves as an associate executive director of nursing at King Abdulaziz Children's Hospital, as well as interim director for women's health. She brings over 46 years of experience across clinical practice, teaching, and research within various leading healthcare organizations in the UK, in the US, and in the Kingdom of Saudi Arabia. She holds a doctorate in science with a clinical background as an advanced nurse practitioner and has a master's in education. And her training includes specialized training in pediatrics and special needs care. Throughout her career, she has commissioned 5 hospitals across the UK and the Kingdom of Saudi Arabia and is currently finalizing a book on hospital commissioning phases. She's also led multidisciplinary teams to achieve WHO and UNICEF baby-friendly hospital accreditation. Dr. Caswell's presentation today is titled High Quality Health Systems for Women's Health, Time for a Revolution. Welcome, Dr. Caswell.
She's muted.
So sorry. Can you hear me now? So sorry. I will share with you in just one moment. Okay, thank you very much. It's an honor and a privilege. Thank you very much for inviting me today. I'd like to start, mine is a broader approach to this. So as you can see, okay, sorry. I'm sorry. Yeah, I'm trying to do so. Can you see now? Do you have a copy of mine? If you could possibly share that, because I'm having difficulties, I apologize. Let's see if I can do this here. Is it now shared? I'm sorry, I'm having technical difficulties. Could you share the one you have, please? All right, thank you.
So I think based on the fact that we have to take care of the technical difficulties, we will have Dr. Caswell present towards the end as time permits. And now I'm delighted to introduce our next speaker, Dr. Razaz Abualhamyel. Dr. Abualhamyel is a senior obstetrics and gynecology consultant and a dedicated leader in women's health in Eastern Province of Saudi Arabia. With over 20 years of clinical experience in OB/GYN, she's widely recognized for her commitment to delivering high-quality, patient-centered care and advancing women's health services across the region. In addition to being boarded in OB/GYN, she has completed a Saudi Adult Critical Care Fellowship, bringing a unique combination of expertise to the field. She is a strategic leader and a change agent, actively contributing to healthcare development and quality improvement initiatives to improve patient outcomes and drive innovation in clinical practice. Dr. Abualhamyel's presentation is titled Social Determinants of Women's Health in Low and Middle Income Countries. Welcome, Dr. Abualhamyel.
Hi, how are you, Imrana? I'm very honored to be part of this collection of outstanding experts. It's my pleasure to give this lecture. It's a very important topic to address. And I want to highlight our strong commitment to support undeserved population. We're going to start about reviewing how the modern health system is complex, which compromises systems that there's individual parts that affect each other. So this system is more importantly should be focused on patient experience and grasp the impact of the system design on patient and recognize connections across industries, then analyze global comparisons to better understand health system. So we have seen great advances. In technology and medicine over the years. For example, we have now automated artificial intelligence ultrasound that can be available in rural areas where midwives and junior doctors can assist patients and give us feedback for high-risk patients through telemedicine or through any communication. But the problem is most of them are not achieving treatment targets. And this basically is rooted by the social determinants of health. And to address this, more importantly, we need every stakeholder in the healthcare ecosystem to better understand this field and focus on them so we can close the gap. So what are social determinants? Social determinants are the conditions in which people are born, grow, and work, live, and age. These significantly affect health outcomes and contribute to health inequalities. Social determinants can be categorized to socioeconomic status, education, social and community contexts, healthcare access, and neighborhood and physical environment. There's also intermediate determinants, which are immediate conditions like housing and neighborhood safety and access to healthcare facilities. These are shaped by more prominent structural factors such as socioeconomic status and broader social political contexts. The link between social conditions and health has been known for centuries, and which reveals that the social gradient in health and in which individual health outcome incrementally improve the socioeconomic status. So we see that poverty, limited education, gender inequality, these all restricting women decision to making power decision. So also there's systemic biases, unfamiliarity with healthcare system, and social justice, which affect eventually the maternal health outcome. So and circumstances that surround these, where people are having this factors, where they reside, where they age, we can see that the health outcome and quality of life are integrated. For example, if we review the maternal mortality globally, if we review the risk of maternal mortality in Sweden, it's 1 in 12,685. While in Chad, it's 1 in 10. So you can see the disparity between the countries. Let's review USA. If we review the maternal mortality in USA, we will find that it's 1 in 3,000. With disparities in the same country regarding Native Americans, Hispanic, and African Americans, where they are 2-3 times higher in maternal mortality. So why we have such discrepancies? Why the rate of mortality, like in the USA, is despairs? Because basically there's limited access to vulnerable categories. So let's go back to Sweden and review why Sweden has less maternal mortality, because they have robust universal healthcare and they have a very good social cohesion. They have a very strong education system and a well-developed socioeconomic structure. While in Chad, it's still a developing country with poor healthcare system and inadequate education and profound poverty with food insecurity. So, the inequity is major. So all of these factors contribute not only to desperate maternal health outcome, but also to other variety of conditions. So we need to review why between 20 and 2022 there's decrease in maternal mortality, because we found there is increased skills attendance. More mothers are attended by a trained healthcare provider during childbirth. There is improvement in emergency obstetric care. There's also a very effective family planning access, where high-risk cases are provided with contraception measures, which decrease maternal mortality. Also, there's improvement in socioeconomic factors. There's improvement in the infrastructure of healthcare system, like housing, electricity, and education of health workers. All these factors improved the maternal mortality. Also, there's a lot of focus on the policy and accountability. So, the high maternal mortality in low and middle income countries result from combination of modifiable and avoidable factors related to the patient, health worker, and health system. So let's ask a question. Approximately what percentage of individual health do you think can be attributed to social determinants? Let's think. Surprisingly, 60%. 60%, while 20% affects genetics and 20% is affected by medical care. So these gaps between the scientific and technology achievements are impacted by these social determinants. So no matter how we improve in healthcare, if we don't go and fix the rooted social determinant factors to improve them, we will not achieve our goals. So this is really depressing, because we only reach few basic treatment targets. And this is a huge gap that we need to close. So what do you consider to be the top 3 determinants of good maternal health? Access to quality maternal health care, skilled birth attendance and emergency care, female education and empowerment, socioeconomic status, and environmental safety. We can review this. This is like an example if we want to do a root cause analysis. Despite all the measures that the multitude global effort to decrease maternal mortality, the figures from low middle income countries have remained poor and discouraging. For instance, although the global maternal mortality declined from 339 to 223 per 100,000 live birth from 20 to 2022, which is an equivalent to 34% decrease, still there's a total death of 28,000 maternal deaths in 2022 in low and middle income countries. So what does that mean? It means that all the effort to improve maternal care all over the world, we're still having increased maternal rate in the low and middle income, which is affecting the global percentage of maternal mortality rate. If we review the maternal mortality rate in East Ethiopian countries and in African Saharas, we will find that there's the numbers of deaths are persistently the same, which accounted for 69% of global maternal death, nearly 70%. While if we review the East European countries during the same period, which has declined from 38 to 11 deaths per 100,000, which was marked improvement. If we want to know the numbers, like the highest number of mortality rate is in South Sudan with 1,223 deaths, in Chad 1,063, in Nigeria 1,047. So, in recognition of women's improved health and addressing inequities, it's critical to achieving this sustainable development. So, we need to, the social determinants are multi-dimensional. It's encompassing political, socio-cultural, and economic and environmental factors. This extends beyond biomedical causes. So if we review, there's a lot of studies done over the last decade. And if we review, most of them addressing the reason for this poor maternal outcome. So if we see here in Ghana, they did a study regarding antenatal care. They noticed that only 50% achieved optimal antenatal care. The service and facilities available, but there was no improved utilization of these services. Also, in the secondary analysis of the Ethiopian DHS, they found that there's lower level of antenatal care awareness all over the area. The same thing in Dibaba Difal, they found more than 50% of postnatal care utilization education. In the southern Ethiopia, they found that there's barriers to receiving healthcare services, basically because of the distance of healthcare facilities. There's long travel times, unavailable of transportation, extended waiting times. This make patients not seeking healthcare. Also, a very important review was done by Trissa in the southern Ethiopian area, where they noticed that maternal satisfaction with labor delivery is an essential indicator for healthcare access. So when they reviewed mothers who are happy with their delivery and birthing experience, they noticed that this is an indicator of access to quality healthcare. So the need for addressing systemic barriers such inadequate healthcare infrastructure, unequal resources distribution, and restrictive cultural practices that limit women's access to and utilization of maternal healthcare services. Still, we have a lot of teenage pregnancies. There's a lot of cultural issues in Africa and India that in other countries that's affecting adolescent pregnancy. So nearly 21 million girls aged 15 to 19 become pregnant, and about 12 million giving birth. There's a lot of talk about sepsis. I'm not going to go and repeat what my colleagues addressed. I just want to focus on how basic little interventions can improve health outcome. Here we can see when they reviewed 44 studies and compensating nearly 140 million pregnant women from 24 countries, they found that the maternal sepsis was 13 per 10,000, and with a variation, the highest crude incidence in the African region, while the lowest is in the Americans, with difference from 129 per 10,000 to 6 per 10,000. This is the review regarding the maternal deaths. We can see that the darkest red area is more critical, and this is what we really need to focus on, addressing social determinants to improve health outcome. The impact of low and middle income countries on sepsis, there's gender inequality, there's culture barriers, which affects access to healthcare. Also, there's health system barriers, basically limited ICU access, a shortage of trained staff, poor infection control, and delayed referral system. Maternal sepsis is a major cause of maternal mortality, and it's preventable with early care. One example is the GLOS, the Global Maternal Sepsis Study. What they did, they reviewed 700 facilities in 52 countries, and they reviewed nearly 3,000 pregnant women. They found that the early identification and management of infection found that 70% of women received antibiotics in the first 24 hours, improved outcome. 40% were infections were identified through clinical examination. 64% of women had full set of vital signs measured in the 24 hours after suspicion of diagnosing infection. This little basic measures improve lives. Also, they reviewed home delivery in Africa, basically in Ethiopia. They found that there's an issue to address the delays of pregnant women seeking healthcare facilities. And the Federation in Ethiopia did intervention. They did an initiative with a slogan, "No woman should die while giving life." And general motto, home delivery free Kabbalah, the women also they did an initiative, the Women Development Army also plays a critical role in minimizing the magnitude of home delivery. So no woman should die while giving birth. A really positive story, which it's really a profound effect, that one of the causes of maternal mortality is uterine atony and postpartum hemorrhage. Because of the uterine atony, it's approximately accounting for 2/3 of PPH cases. Fering did a study, and this study was really transformational. The vision was that every woman giving birth should have care and medicine to help them build families regarding where they live. So they tried to do and invent a heat-stable Carpitocin, which is a landmark achievement. And this collaboration improved maternal outcome and prevented maternal deaths from PPH. So there's strategies to improve the framework of social determinants. There's a lot of effort. One of them, the Maternal Mortality Initiative in 2023. They did strategies to improve the provision of quality and sustainable healthcare. Second strategy, reduction of socioeconomic disparities. Third strategy is engagement and international collaboration. Basically, very simple things like addressing systemic barriers, like fixing inadequate health infrastructure, unequal resource distribution, education. There's a lot of focus on education of the patients, education of healthcare workers, early disease screening, enhancing governance, and there's a lot of interventions. If we see this rainbow model, we should focus on each level with an intervention to get an improvement in an outcome. So they noticed that there's a huge trust deficit between patients and governments in the low and middle income countries. So it's easier for women to listen and accept messages from trusted gatekeepers from the instead of the government. This needs to be intervened because this will improve the cooperation and the effective management. So establishing a national confidential inquiry to maternal deaths is an important also initiative to address the causes and the root causes for the social determinants of health. This is a review on how reducing maternal mortality, if we do like a commitment with a political will, investment in critical health and social infrastructure and education, we will have improved outcome. So there's social vulnerability index and city health dashboards. These is tools to improve the social determinants. So each country should have this addressed, like we review in each country, which is the social vulnerability index, what is the city health dashboard, and yearly we do measures to improve. This is an example of the overall vulnerability index, and this is the dashboard, an example of the dashboard. The solution is to evaluate social determinants and clinical practice and the role of multidisciplinary team. So we need an integrated care team where they intermediately focus on healthcare professionals. So we need pharmacists, we need community health workers, we need social workers, we need patients navigators and education specialists and physician-focused patient. So basically we need collaborative care. So the emphasis, the need for upstream prevention to address the root causes of health disparities and promote overall population health. Many deaths are preventable. Inaction is passive discrimination. Women are disproportionately affected. Equity-focused healthcare systems are essential. Addressing social determinants save life. Thank you.
Thank you so much, Dr. Abualhamyel. This is an excellent presentation on how huge this problem is and what how multi-layered it is in trying to address it. This really underscores how many different components need to work well in order for us to move these outcomes and get to the level of what other high-income countries are routinely able to do. So definitely appreciate your education and update on that. I am watching the chat, and we have excellent representation from around the world. We have Central Africa, we have Argentina, we've got Bolivia, Gran Canaria, so and people from Oman. So thank you to everyone who's been joining in. In terms of questions, I'll start it off by saying that obviously the social determinants of health are a huge problem. They've been a huge problem ongoing. And when we take a look at what is needed today in 2026, it seems appropriate that maybe each region would have to define its own top priorities for opportunity for improvement. But in your estimate, sort of globally, are there one or two top priorities universally that today in 2026 we need to pay more attention to?
On review on this topic, number one is access to facility-based childbirth. So I was surprised with the amount of mortality related to home births. And there's a lot of, what's also upsetting that there's a lot of health work facilities with underutilization due to cultural and social misbeliefs. This needs to be addressed and intervened. So I encourage that we should not, at least if there's a home delivery, it should be integrated with the healthcare system. This is mainly number one improvement.
Excellent. Thank you so very much. And I think in the interest of time, we are going to move on to our next speaker. So thank you very much, Dr. Abualhamyel. Our next speaker, I'm very happy to introduce Mr. Abdulqadir Nashwan. Mr. Nashwan is a nurse scientist and global health researcher based in Doha, Qatar. He serves as an executive director of nursing and midwifery research at Hamad Medical Corporation, and is a PhD candidate in health sciences at Qatar University. His work focuses on patient safety, infection prevention, and improving outcomes among vulnerable populations. He has contributed extensively to advancing evidence-based nursing practices and strengthening healthcare quality. Also, he is actively involved in global health initiatives, including the Global Burden of Disease Study. As a certified global nurse consultant, he's committed to advancing safe health quality care in diverse and resource-constrained healthcare settings. Mr. Nashwan's presentation today is titled Safety Standards for Immunocompromised Patients in the Eastern Mediterranean Region. Welcome, Mr. Nashwan.
Thank you, Imrana. It's my pleasure to be here with you and to have all the expert colleagues and also the audience from all around the world. So I'm privileged to be here. And I will have a very short and sweet presentation. So I was under the impression that we have 10 minutes. So let's stick to the 10 minutes to deliver, head to the point, especially the very interesting part, which is why most of the interventions and strategies fail to answer the questions when it comes how we improve the stewardship and infection control practices around the world. So stay tuned to the last slide because I will try together to answer that question. So for the ones that they are not familiar with I'm not sure if you can see this. Yeah. Trying to move the slide. Let me just share again. Yes. Yeah. So if you look at the map, this is the Eastern Mediterranean region. We have countries from Pakistan to Morocco, variety in terms of and diversity in terms of the socioeconomic status, the economy, the population, even the weather and the collective way of how each country is different from the other, race, ethnicity. So it's a diverse region. So also it's diverse when it comes to the diseases. As you can see, this is the WHO EMRO reporting infectious disease outbreak only in 2019. So as you see, we have differences also from country to another. What I didn't put on the map here is a very important factor contributing to the health of each country, which is the conflict. If you are familiar with this part of the world, that almost every country on the map here, it has a conflict, either ongoing or previous, just trying to recover from that conflict, or even they are at risk for a potential conflict in the future. So this is very important factor. This affects also in a way or another, either immunocompromised patients or even other patients. We know that there is a shift already in most of countries from communicable diseases to non-communicable diseases, but we can see how both of them are interrelated, especially with the example here for why this matters. Because when we talk about immunocompromised patients, we are talking about high-risk group, where patients, for example, with cancer, that it's linked to obesity, it links to infectious diseases and the complications. So when we talk about immunocompromised patients, we are talking about higher infection rate, prolonged hospitalization, morbidity and mortality and complications, and ultimately, we are talking about the cost, while the entire world is discussing the value of care and how we can optimize with the limited resources that we have, especially with low and middle income countries. And as you can see that most of Eastern Mediterranean region countries are low and middle income countries. Even the ones that with high income country, now they are facing other challenges when it comes to the epidemiological shift that I spoke about, moving from communicable disease, non-communicable disease, high rate of the obesity, diabetes, and ultimately we'll have more cases of cancer, chronic kidney disease, and the link between what we mentioned earlier. Especially, as I mentioned, many, they have resource constraints and system variability when it comes to how they run hospitals, the community also, because every time we talk about healthcare system, we focus on the tertiary or secondary part. We mostly ignore the primary healthcare, which usually the burden has to be more rather than the shift that we have more burden on the secondary and tertiary. And what we need to do is, and this is maybe part of the discussion by my colleagues earlier, how to move it to primary level where we can prevent this early detection before it happens, and especially with antenatal care, for example, or newborn at early stages. So if you are not familiar, maybe I know that from the audience that maybe we have also students or somebody who is not quite familiar with the concept. Immunocompromised patients, we have different types. This is all due to the weakened or impaired immune system. It could be related to certain diseases related to the pathophysiology of the disease, like cancer, HIV, AIDS, chronic diseases, chronic kidney disease, or using some induced by therapies that for the oncology. And cancer itself, it's impaired the immune system. Also, the treatment for cancer using conventional chemotherapy. Now we are moving toward more targeted, but still we are facing this, especially when the availability of medications can't be afforded by certain countries. So we expect that the patients will be immunocompromised. As I mentioned, oncology patients, transplant recipients like after chronic kidney disease, kidney transplant, patients on hemodialysis, children and congenital disorders. This is also very important part of this population. So what are the key safety risks that we are looking for here is the degree of immunosuppression, underlying disease, and environmental exposure. And I'm not sure if everyone is familiar with what we call currently the One Health or planetary health. They are using this interchangeably. Maybe planetary health is much more inclusive, where you are not looking, if you want to design a healthcare system, you don't design it just based on hospitals, tertiary, secondary. Also, you look at the bigger picture, you consider the environmental health, the animal health, plants. So everything will be considered. The design is very important. I will come to this toward the end of this presentation, how improvement by design is much more important than anything else. And when we consider this by designing hospitals, I disagree with my colleagues. They mentioned that sometimes the mortality at home for birth at home is much more the hospitals. Well, if you look all the reports, and the famous report in 2000, it was issued by the Institute of Medicine at that time, was called, and very famous report, Human is Error. You found that in the US alone, more than 100,000 patients, they died due to avoidable mistakes by humans. So hospitals supposed to be a safe place. Unfortunately, we are not doing, as healthcare providers, the whole system not doing very good job when it comes to this. And there are some initiatives moving this to the community and away from hospital. This is another perspective that we need to look at and to see how to do it, but not with the same measures. This is my also a perspective. We can't do it the same. We need to redesign the entire health system around the person rather than around the convenience of healthcare provider or budget and system or these things. That's why we have the term of person-centered care. We need to look at this from their perspective and to see how we can accommodate this. If we have no-show, for example, high rate of no-show for antenatal care, this not because people, women, they don't want to come, but this has to do also with the policy. I'll give you an example. For example, when you have certain conflict, threat, and you move to online education for kids, the policy doesn't account for something more important, which is aligned with this. The women, who's going to sit with kids if they do it online? If women, they go to work. So the policy has to account for both of them. The same thing you apply it here when it comes to hospitalization. So this is very important aspect. When it comes to the system level gaps, there's a very famous report by the WHO, multiple publications, very important publications, especially for low and middle income countries in the Eastern Mediterranean region. They highlight very interesting things. I just summarize them, that we have limited infection prevention systems. Almost more than 50% of healthcare systems in the Eastern Mediterranean region, they don't have established infection control, infection prevention system. Means that also linked to the second point, they don't have workforce, either nurses or infection control practitioners, then also clinicians and physicians. So the entire system is working together. So it's not about only the availability of one aspect of the system. And therefore, we have weak surveillance system when it comes to stewardship. In many countries in the Eastern Mediterranean, you can go to any pharmacy, you get whatever the antibiotic that you want to get without certain restrictions when it comes to this. But still, we have variability, as I mentioned, in some countries in the Eastern Mediterranean, especially in the Gulf region, this was implemented for some time, and you cannot get this very easily. At the hospital level, it has to be stamped by the infectious disease clinician for certain type of antibiotics, so it is not as easy as before, and accessibility. So what are the core safety standards that we are looking for to strengthen the system? First, the infectious prevention control. The system has to be well established. Then safe clinical care starts with the vaccination, early prevention, as we mentioned. We know that vaccination, it's a proven, evidence-based, the best practice that you can do to prevent diseases, starting from childhood, even for adulthood. Immunocompromised patient may have atypical delayed symptoms. That's why we need to early detect, especially when it comes to sepsis. Sepsis is very critical in patients with immunocompromised. My colleagues spoke about this, and it's very important to highlight. I'll come to some aspects when it comes to this. So when we look at the equity lens, because we are looking here in this session at newborn children and women, we are talking about vulnerable population, that they have more limited access to care, delayed diagnosis due to lack of resources for differential diagnosis, even early detection and screening programs, and gender inequalities. My colleague also mentioned about the women, that also they face inequalities, disparity, delayed care seeking, that's part of the culture also. This is very important barrier, and very important part and factor is restricted decision-making autonomy, because many countries in the Eastern Mediterranean, for example, the mother doesn't have the right to sign an informed consent. That's a very important part also needs to be tackled, and plus the cultural barriers, which I think we have a lot of examples about it. Pediatric dependency also still, and I remember from my research when we introduced the S10 form to be signed by kids, it was something, and we had difficulty to implement this, to say that kids, they have to agree to be part of the research. It's not just the parent or the legal guardian to accept. So the recommendations, this is the interesting part that I want to share, and you can apply this not just in immunocompromised patients or the infection control part. Also, this could be applied all the intervention. I came from a nursing background. I attended hundreds of meetings related to patient safety, performance, and the quality of care. Every time people are asked to propose interventions to be implemented to improve something, they raise their hands and they say, let us educate the staff. Even if it's for hand washing, whoever from the healthcare provider doesn't know that hand washing is essential and saving lives, everyone knows. But when you go to the reality, you find that compliance rate, the actual compliance rate, is maximum will be 20%. Why? Because we are humans. This is part of our nature. We don't like to comply with rules and regulations. That's why, and I've been doing education for the last 15 years, and it's very strange to come from my side to say that education is not the answer. Education and training is the least effective intervention, as you see here in the what we call it hierarchy of intervention effectiveness. Is a very interesting thing that I'm surprised that many people, they don't know about it. So why? Because education training is more people focused, as you see here. When you go a little bit up, you do better interventions like rules and policies, reminders, checklist and double check, simplification and standardization, automation and computerization, then forcing functions. Let me give you an example from immunocompromised patients, for example. If you rely mostly on training, nothing will change. Einstein said, doing the same thing and expecting different results is insanity. Don't do that, because this will not do any difference. Education is very important. It's part of every step here, but it's not the answer. You cannot rely on. What you need to do is to go further. Rules and policies. For example, you can have the protocol neutropenia, the golden hour for antibiotics, You can implement this, but policies by themselves are not enough because we have plenty of policies. Many of you relate to this, but the compliance is an issue. So how to ensure that we have the better compliance? We have to help people to comply, not to add more layers and more complicated policies. Reminders and checklists. Back to Dr. Zulfiqar, he mentioned the human resources, that like training, education, optimization, and regulation. So I can relate, but this is more explained here based on evidence, what it works, what doesn't work very well. So reminder checklist and double check, for example, for certain medications, you have a double check to ensure that 2 nurses, for example, they administer the medication. The checklist also for preoperative, for example, this is another example. So this is if it's implemented in infection control. Also for isolation, this is very important. Simplification and the standardization, the bundles that Dr. Zulfiqar mentioned earlier. This is very important, evidence-based. We know it works. Make it simple, bundle, and standardized across the healthcare system so you don't face a difficulty for implementation. Having a standardized language, it's very important. How to define sepsis, it's very important. Automation, computerization. For example, the electronic health records, the facilities and the hospital, they have electronic health records. This is very important part where you can generate alerts. You can highlight the contraindication for certain medication. Having 2 or 3 antibiotics at the same time will be flagged by the system. This is very important part, but keep in your mind, there's something called alert fatigue. So people, by the time, if you have multiple alerts, not only for this, have multiple alerts for documentation, for everything, they tend as humans to ignore and override. So what is the best intervention? Forcing function is redesign the system to make it mandatory, so you cannot override it. My colleagues, they mentioned some examples about this, how we can do this, and we end up with having a good design of the system. Rethinking the design of modern hospitals is very important. Our design was not updated since ages. I give the example of the bathrooms in hospitals. Still, we have falls. Still, people, they get injury because we still have the same design since how many years? So we need to rethink the design so we can get the improvement and a better surveillance system. So the take-home messages, very clear: immunocompromised patient at high-risk population requiring specialized safety standards, more precautions, but it's very important that when we talk about this, especially in low and middle income countries, it doesn't need to be costly. Guys, it's very important to see when you look at the literature, you find very cost-effective measures, simple, straightforward, starting with the hand washing, doesn't cost a lot of money, but it can make a lot of difference when it comes to this. In the electronic health medical records or health record system level gaps, not just the clinical factors drive poor outcomes. Currently, the use of AI is very important. Low cost, could be used, implemented. There are many initiatives, even at different levels. I know about 1000 Horizon. This is led by Bill Gates or Gates Foundation for Africa to strengthen the primary healthcare and by providing access to AI to help clinicians, practitioners, GPs to provide instant care and to provide also guidance, decision support system particularly. Education and policies are important, we know this, but they are the least effective. Let us move towards more effective interventions, not to waste our time spending time educating without any benefit. Safer care comes from system-focused intervention. Redesign, rethink the design, improvement by design. In Japan, they call it Boki-yoki, so improvement by design. And this is all the improvement science came from that root. How to improve by redesigning things. Equity must be embedded in safety. Vulnerable, newborns, children, women are vulnerable. They need extra precautions. They need better interventions. They need policies to be tailored to accommodate them. rather than to accommodate something else. So we need to be vigilant when it comes to this. With this, I end my presentation. Thank you very much. And if you have any questions, thank you very much.
Thank you so much, Mr. Nashwan, for this sort of comprehensive sharing of information from evidence-based focus as well as sort of practical approaches for safety standards. And I think a lot of those work whether you have an immunocompromised population or a non-immunocompromised population. We are getting lots of great questions here in the chat. One I want to share with you from our colleague in Nigeria, Dr. Halima Kubara, asking if there are trust issues in the health system, especially among vulnerable populations. You're talking about immunocompromised patients and such. If you can share about that.
Yeah, thank you very much. I'll back to my colleague point, Dr. Razaz, about the misinformation. This is very important. We see it in the vaccination part. Many parents, let us talk about kids. Many parents, they don't let their kids to undertake vaccination due to mostly misinformation. And this is an embedded issue. It is not just rooted in history related to mistrust in government healthcare system. So this is a good example. If we move healthcare system into more person-centered rather than, as I mentioned, the convenience of clinicians and healthcare providers, I think we gain the trust and we can see how the healthcare system is more transparent and people will come and comply. I gave the example of no-show. Why we have high rate of no-show, even though that we are dealing sometimes with adults, they know that it's good, they book that appointment, but they don't show up. What's the reason? Because I always say that it is not their issue. It is the healthcare system that it's not designed. For example, if they want to cancel, they need to call multiple times. They might not reach. That's the reason. So make it more efficient. Maybe AI will help us a little bit to come into this. Easy cancellation, easy rescheduling, but make it more efficient system rather than to waste the time, because the no-show also affects the system by not accommodating people and you have a long waiting list. So rethinking the way how we do the business, I think this is the way that how we regain the trust.
I definitely agree. Thank you so much for that response. An additional question is that implementing and sustaining safety standards can be very challenging even for high-income countries. So how are healthcare facilities in LMICs expected to do this more effectively?
Thank you. This is, I think, the hierarchy of intervention effectiveness is applicable everywhere. Just look and rethink the interventions that you have. Don't waste your time doing something already been proven it doesn't work. Rethink the way how you do your interventions, redesign. You will be surprised by how much improvement that you have at your healthcare system. Resources is a challenge for everyone, high income and low income countries, but also the innovative way that how many countries are started and they've been doing for a long time. I think this is very good example. Learn from other countries. Don't start from the scratch. Don't try to reinvent the wheel. Check the evidence, what the evidence says, and you will be surprised by how much that you can save time and money doing something better for your healthcare system.
Thank you so much. Really appreciate your input and your responses to the questions. We will now move on to our next speaker. I'm pleased to introduce Dr. Naomi Spotswood. Dr. Spotswood is a neonatologist and clinical researcher based at Royal Hobart Hospital in Tasmania, Australia. She is currently completing a PhD through the Burnett Institute focused on understanding and improving the diagnostic process for neonatal sepsis. She is strongly committed to improving neonatal care and health equity through clinical practice improvement. She's a member of the Australian and New Zealand Neonatal Networks Council and has contributed to the sepsis clinical standard for the Australian Commission on Safety and Quality in Healthcare. Dr. Spotswood's presentation today is titled Quality Newborn Care to Improve Sepsis Outcomes. Welcome, Dr. Spotswood.
Thank you so much, Imrana, for that introduction. So hello, everyone. My name is Naomi. I am a neonatologist and a clinician researcher. I work clinically here in Australia, and through some other clinical work, research and education, I also really enjoy working with and learning from colleagues all around the world. And today I will be speaking to the importance of high quality newborn care for improving sepsis outcomes. Something I really love about my job is that I'm part of a variety of initiatives that improve the quality of care that we provide for babies and their families, particularly for neonatal sepsis. And that is very much team-based work. We all know that quality does not occur spontaneously. It's something that we need to actively work on to achieve. And so over the next 10 minutes, I'll spend a little bit of time talking to some of the things that I've learnt and observed from being part of that work. Many of you might be aware of WHO's newly released strategic objectives for the development and implementation of maternal, newborn and child health quality of care programs. I'd encourage you to take a little look if you have a moment. In that resource, they name up the action levels that are needed to ensure that quality care is delivered. So there's the macro level, generally national, which involves really strong healthcare leadership. And then we have the meso level, which is all about operationalising priorities for quality newborn care. And each of those levels is really important, vital, in fact, for setting up health systems and hospitals, health facilities well for implementing quality newborn care. And then there's the micro level, and that's direct delivery of care to neonates and their families in the healthcare facilities that many of us work in. It's the level that, as clinicians, we often resonate with the most because it's our daily work. And so that's the level that I'm going to focus on most in this talk. It's work that needs many different people and skills, problem solving, sometimes creativity, and it always has babies and their families at the forefront. So to start for scale, as some of our other amazing presenters have, I always find it really helpful to think about absolute numbers. So if we take just a couple of years ago, in 2023, 132 million new people entered the world, and that's 132 million babies who took their first breath and met their families for the first time. Almost 2.3 million of those babies died, many in low and middle income countries. Each of those deaths is a tragedy and many are preventable. And so of all those babies born each year, up to 30 million need some extra care, and that's often in a hospital or healthcare facility. And from varied estimates out there, up to 5 million of these babies will have infections or sepsis, which will cause at least 500,000 of them to die. We know that neonates as an age group are exquisitely sensitive to the quality of the care that we provide to them. In one study published in The Lancet in 2018, greater than 60% of deaths due to neonatal conditions occurred due to poor quality care. And so it's really important that we deeply consider what quality for care for newborns with sepsis looks like and how we can achieve it. And so let's start with what newborn sepsis care involves. So there are three basic elements. First, we want to prevent sepsis from happening in the first place. Then, if it happens, we want to recognise it promptly so we can get on with treating it effectively. And then we can think about what quality care looks like. There are a variety of ways that quality of care can be defined, but these three core descriptors from WHO's resources are really helpful. So quality care should be effective. It needs to be evidence-based care that's going to work for the condition we are treating. It needs to be safe. We want to avoid harm. And the third descriptor is people-centred. Although when we care for babies, the term family-centred fits much better there. Care must be responsive to a family's needs and values. We can't care for babies without caring for their families. And so putting all of that together, we can paint a little bit of a picture of what quality newborn sepsis care could be. And there are a few example elements that I've put here on this slide, and they really focus on those first two core descriptors, effective and safe care. And so we can start with prevention. There's primary prevention, which actually starts with quality antenatal care. Preventing prematurity will prevent infections. And then in our healthcare facilities, there's infection prevention procedures that ideally prevent all or nearly all healthcare acquired infections. We need to recognise sepsis promptly, and we also want to avoid antimicrobial overuse. And then we really want antimicrobials that are effective against all of the pathogens that cause neonatal infections, including the multi-drug resistant pathogens that we here in Congress are so concerned about, together with effective supportive care. And so while we know what it should look like, we know that that isn't always what's delivered. And there are many reasons for that. First of all, for prevention, antenatal care is often fragmented, and we know in our work environments, we are busy healthcare workers and we don't always work in optimal conditions. We have high workloads and there is crowding, and there are a whole lot of barriers to preventing infections. We know that it's actually really difficult to clinically diagnose neonatal infections at an early stage. And then in terms of treatment, we see lots of prescribing inconsistencies worldwide. And of course, we're all concerned about the impact of multi-resistant infections. And so we might move then to think about what could quality care look like in the future? What could be better? What could be developed? And so there's so many exciting things that we've heard about here actually in this Congress that could improve quality in the future. And many of those are around infection detection, particularly bringing detection to the bedside, and also some advanced detection techniques using AI platforms. Then ideally, we would have universally available core supportive care infrastructure to support the multi-system dysfunction that newborns experience when they have sepsis. And we're all waiting to see where we'll get to in terms of new antimicrobial development for multi-drug resistant pathogens. And the researcher in me really would love these things now for the babies that we care for. And I have optimism that we will get there. But the clinician in me knows that our best approach to quality care is to ensure that we work really well with what we already have. So let's think about that. Oh, let's move that forward. What do we already have? And so I've put some things up here on the slide that I think many people in the audience will already be very well aware of. We know that there is excellent evidence for good hand hygiene, really consistent following those 5 moments, and asepsis around procedures and contact moments with the newborns that we care for. Infection prevention bundles are proven to be really effective, particularly for infections associated with vascular access devices. We know that there are clinical sign-based infection detection methods. They're not perfect, but they are evidence-based. And I think, again, this audience will be well aware of the integrated management of childhood illness danger signs and the importance of ensuring that healthcare workers have a really good understanding of those danger signs. Judicious antimicrobial use is really important. We want to make sure babies who have sepsis receive antibiotics, but babies who don't have sepsis avoid antimicrobials and their risks. And finally, family-centred care. So remember, that was the third descriptor that we talked about for quality care at the start of this presentation. And that's where I think the money is. That's what we really need to focus on. So let's talk about that a little bit more, starting with family integration. And so I said at the start of this presentation that we can't care for babies without caring for their families. And I'm going to take that concept one step further now. We can't care for babies well unless we do that care together with families. Quality newborn care needs to really be family integrated care. And that's care where we start to really empower families to be primary caregivers for their baby in the hospital. We not only make sure it's family-centred, but we recognise and respect families as key caregivers who have strengths and knowledge beyond what we can have as healthcare workers. They are well-informed experts in their baby's care and key advocates for them. And another really amazing part of a family-centred or family-integrated approach is kangaroo mother care, which we've heard about a few times over this Congress, which I've really been delighted to hear. So kangaroo mother care is one of the most effective interventions that we have to both reduce sepsis and reduce sepsis mortality. I know that this audience will be well aware of the impressive trial results from the IKMC trial, with a 37% reduction with sepsis mortality with KMC. And those results stand to systematic review. I've referenced 2 systematic reviews up there that each show really impressive risk reductions with the use of kangaroo mother care in comparison to standard incubator or cot care for babies. And so family integration, I think, is one of our core and key strategies for improving sepsis outcomes in newborns and delivering quality newborn sepsis care. And if we think about what that looks like, it starts with prevention. So families are part of infection prevention processes. These are families who are empowered and confident. So if I'm in the middle of a really busy shift, a mother might say to me, Dr. Naomi, you're about to examine my baby, but I think you just touched their cot. Could you use the sanitizer? And my response to that is, oh, thank you. We really need to ensure that families are able to be part of infection prevention and advocate for their babies. We know that increased breast milk feeding can reduce infection, and also the protective approach of ensuring that the microbiota from the mother is effectively transferred to the neonate. Recognition, I think, is something that we're really beginning to understand is challenging for all of us, but could be improved with families. And so what I've observed in some recent work at Fame Hospital in rural Tanzania is that families who are part of KMC, who care for their babies every day, who are always with them with essentially zero separation, are incredibly in tune to their babies. They know when their babies are well, and they know when their babies are getting sick. And what that can look like is a family saying to me, Dr. Naomi, my baby's different today. And we might then sit down together and examine their baby, and we might say together, could it be sepsis, and get on with treating them at an early and effective stage. And then finally, for treatment and recovery, we know that families who are able to experience the benefits of KMC have improved bonding and attachment and reduced stress. And all of those things are always good things. And so I'll finish by saying that I think that family integration with KMC is a highly valuable, underutilised approach for neonatal sepsis prevention, recognition and recovery. I put an image there of WHO's quite recently released clinical practice guide for kangaroo mother care. And if you're in a situation where your facility has decided to transform your care from a cot or incubator model to a KMC model, I'd encourage you to take a little look at that guide. And when you start to implement it, talk to families about how to do it. They'll likely bring amazing ideas that really enhance the care that you can provide for all the babies that we care for. Here are some resources that I found really helpful, and if we have time, I'm very happy to take any questions.
Thank you so much, Dr. Spotswood. Excellent overview on very practical approaches of what you can do to improve some of these outcomes. And we do have quite a few questions here. I'm going to start with one question in terms of the quality care based in family integrated approach. Can you speak to what that looks like for quality newborn care to continue after the babies leave the hospital? What do you do with the families afterwards?
Absolutely. I think that depends a little bit on your context. And so I'd say for my work as a neonatologist here in Australia, one part of my job is that we support families before they go home, and then beyond their discharge. So we regularly see families in a clinic, and that's a multidisciplinary clinic that I really enjoy being part of. And so our team really words families up around what to expect in terms of supporting their baby and their baby's development. And then they have those touch points with us where they can ask questions and we can chat with them about how to best support their baby's development, and also just have a general chat, because having a baby in a neonatal unit or in a hospital is a really stressful, it's a seismic event for a family, and being able to talk through what that meant and what it means for their family in the future is really important. So support for babies after they've left the neonatal unit, particularly if they've had sepsis, is really vital. And yes, absolutely part of quality care.
Great, thank you. We have a comment in the chat from our colleague, Dr. Nayoko from Kyoto, saying, thank you for sharing the importance of family integration. I appreciate the opportunity to reflect on how essential it is in patient care. So thank you for bringing that to the forefront. One of the other questions asks, when babies are ill and they have sepsis, there's quite a few steps in sort of improving their outcomes. So how can health services ensure that their quality improvement initiatives for newborn care is successful?
Yeah, I think the core of all the quality improvement we work work that we do is data. And so having really great accessible data is important. And we heard earlier in this session around how it's so important it is to know what the pathogens are in your unit. And I'd say also there's lots of metrics that you can do, and sometimes it's about choosing where to start. But if you sit down as a team and think about what are the important elements for quality care and what do we think we need to improve on, some examples might be time to antibiotic administration, what's our line sepsis rate in our hospital, choose something and then go through some plan, do, study, act cycles that are informed by data. The other side to data is that data isn't always numeric. And one thing that we're starting to do a lot more in our neonatal units is to recognise that family feedback is a really important part of that data. And so talk to families and talk to staff and, just sit back and really reflect on the insights that they provide to you.
Thank you so much. Lots of conversation in the chat about how the family integrated approach is quite crucial for the newborn babies, especially in recognition of sepsis. So everybody is really following along the line, what you shared, and definitely responding to that. So thank you so much for your presentation. At this point, we will get back to our second speaker. And I think we've worked through our technical difficulties. So I'm very happy to reintroduce Dr. Angela Caswell, who, as we've shared before, is a professor of health studies and currently serving as an associate executive director of nursing at King Abdulaziz Children's Hospital and as an interim director for women's health. So again, Dr. Caswell's presentation today is titled High Quality Health Systems for Women's Health, Time for a Revelation. Welcome, Dr. Caswell.
Thank you very much. I think Naomi has got the slides available, she said. Thank you very much, Naomi. So hopefully apologies for the technical issues earlier, hopefully my presentation will complement those of the previous presentations. So we're looking at a more generic approach to this. And so we're looking at the overview of this presentation. That will be sepsis as a leading cause of global mortality or morbidity. It is disproportionately affects children, pregnant women, the elderly, and our immunocompromised patients. So early detection and timely intervention are vital. This review evaluates global risk burdens, risk factors, screening tools, and targeted interventions with, of course, a very special focus on women's health and vulnerable population. Next. Looking at the background, the scale of this problem, the magnitude, and this is in accordance with the WHO and a more recent publication in The Lancet. The global cases are almost 49 million. 11 million of those result in deaths. 50% of sepsis cases are linked to those under 5 or affect those under 5 years of age, and hospital-acquired infections, sepsis, constitutes 15 in every 1,000. Next. So what is sepsis? It's a life-threatening organ dysfunction caused by a dysregulation host response to infection. It can rapidly progress to septic shock, multi-organ failure, and death. And we've said our high-risk groups are neonatal children, pregnant and postpartum women, elderly, and immunocompromised. Septic shock is a sudden subset with circulatory, cellular, and metabolic abnormalities with higher mortality. And atypical presentations in vulnerable populations are very risky and very tricky and often lead to delayed recognition. Next. So for this presentation, we look at the overview and the key questions. So the objectives, and the key questions. So we review sepsis epidemiology and the global burden, examine women's health risks specific to sepsis. We assess early detection and screening tools that might be available and evaluate the impact on healthcare systems and related costs. And the key questions related to these are: what are the outcomes and the economic costs of sepsis? Which screening strategies are most effective? And how we address disparities in vulnerable populations, and what interventions reduce mortality. Next. So I conducted a very rigorous literature review, a structured literature review using databases from PubMed, Medline, and WHO databases. We did a retrospective of 16 years and in only human studies in English. Our methodology was for PRISMA guidelines as well as JBI framework, and the focused areas looking at epidemiology, screening, management, outcomes, and vulnerable populations. Next. So the key findings, the epidemiology and risk, unsurprisingly for this, the sub-Saharan Africa and South Asia constituted the largest burden. And as we said earlier, that globally we're looking at almost 49 million and 11 million deaths. It's disproportionate burden in low middle income countries with the highest mortality of children and pregnant women. We look at the data gaps that persist in these low resource settings. And the reasons for the sepsis data gaps in underdeveloped countries include a lack of diagnostic infrastructure. Many hospitals lack the basic microbiology labs, making it difficult to identify pathogens and confirm sepsis. And as a result, many cases are not microbiologically documented, leading to a lot of underreporting and missed cases. Resource-intensive definitions, standardized sepsis definitions rely on intensive care monitoring, such as organ failure scores, which are often unavailable and in non-tertiary, rural and district-level hospitals. Under-resourced healthcare systems and staffing shortages. Low healthcare worker to population ratios mean rapid identification of sepsis is often missed, and many patients with sepsis are treated in overcrowded primary care settings. High home or community mortality rates, a large number of sepsis deaths occur at home rather than in a hospital, and which contradicts or disagrees with what one of my colleagues said earlier, and preventing them from being captured in health data. So diagnostic overlap with other diseases. So clinicians in LMICs often focus on vertical disease-specific programs such as malaria, TB, pneumonia, rather than on the syndrome of sepsis itself. And patients are frequently classified by the primary source of infection rather than the resulting sepsis. Limited electronic data systems, the absence of EMRs and standardized international classification diseases coding make it often very difficult to retrospectively or prospectively track cases. And consequently, most sepsis mortality estimates are extrapolated from small numbers of studies in tertiary hospitals, again, which fail to represent the rural population where the major of these cases may well occur. Next. So the pathophysiology and clinical presentation starts with a fever, hypothermia, tachy, hypotension, confusion and altered state of consciousness, tachypnea, delayed recognition in the elderly and children and pregnant ladies. So we look at infection, dysregulated immune system, systemic inflammation, organ dysfunction, shock, and death. Next. Screening and early detection, this is the key. Early recognition, early response, and early rescue are the answers. So some of the early screening tools that we can look at is SIRS, so Systemic Inflammatory Response Syndrome Criteria, QSOFA, which many people are very familiar with. So quick sequential organ failure assessment, MEWS, Modified Early Warning Score, and FAST-M, obstetric specific protocol for maternal sepsis. Now, FAST-M sepsis bundle is a WHO supported toolkit designed for early recognition and the management of maternal sepsis, particularly in low resource settings. It consists of fluids, antibiotics, source control, transport and monitoring, and these significantly improve sepsis recognition and management within 1 hour. With neonatal, the primary sepsis screening tool often used for newborns is neonatal early onset sepsis, so EOS calculator, which uses maternal risk factors and the infant's clinical status to estimate risk. Other methods such as Sepsis 6 protocol for acute management, PEWS or pediatric early warning score, and specific validated tools like the CHBC provincial pediatric sepsis screening tools are also to be considered. So rapid identification is critical. So every hour of a delay increases mortality by 7%. The treatment bundle comprises of IV antibiotics within what's been described as the golden hour, source control and fluid resuscitation. We discussed the FAST-M protocol, which is very valuable, and staff education and simulation training has been demonstrably proven to support and improve recognition rates and outcomes. Next. So special population on women's health, maternal and pregnant women. We've explained that it's a leading cause of maternal morbidity and mortality. They're very high risk for those with C-section. Why? Because the risks of sepsis increases with C-sections primarily because they have had major abdominal surgery that increased surgical wounds, increases the risk of infection, often driven by factors like emergency procedures, obesity, diabetes, or prolonged labor. Post-C-section infection, specifically endometriosis or wound infections, can quickly escalate to sepsis. So we require obstetric-specific management pathways for maternal and pregnant women. For children and neonates, rapid clinical progression compared with adults. 50% of the under fives resulting deaths involve sepsis. Neonates especially vulnerable to low resource settings, and we need a pediatric-specific dosing and protocols. Elderly and immunocompromised, atypical and non-specific presentations are very common. Worse baseline outcomes and comorbidities with higher mortality despite treatment, and immunocompression masks inflammatory markers. Next. So the cost burden, we just looked at this for the US as one example. In the US alone in 1 year, sepsis represents $617 million in readmissions. And that far to the greater economic burden than chronic heart disease or MI. And the direct costs include ICU stays, prolonged hospitalization, and long-term rehab, and the indirect costs of loss of productivity, caregiver burden, and the mental sequelae of for those patients after they've suffered sepsis. And the burden is magnified exponentially in low-risk resource settings with limited healthcare infrastructure. Next. So there are challenges and there are opportunities. So the challenges are clearly inconsistent data collection and reporting across regions, limited awareness and training, especially in resource-limited settings. Antimicrobial resistance complicates management and delays in recognition among vulnerable populations, and a lack of standardized global surveillance systems and support. So the opportunities for us are to develop multidisciplinary team-based models, to standardize our screening tools, invest in workforce education and simulation training, of which I am a great believer. Improve global surveillance and data sharing, and context-specific interventions for low resource settings. Next. So early detection and standardized screening protocols and life-saving and delay cost lives. To invest in health systems, the infrastructure and the workforce training is an absolute prerequisite for this impact. Maternal and pediatric sepsis require tailored and population-specific approaches, and multidisciplinary collaboration across nursing, medicine, pharmacy, and public health is critical. Global disparities remain significant. Context-specific interventions are essential, not optional, and research into novel biomarkers and therapies must be accelerated. Okay, next. So in conclusion, sepsis is a global emergency with profound mortality, morbidity, and economic consequences. Prevention, early detection, and equitable access to evidence-based care are the keys to reducing this burden. Standardized screening tools, staff education, and simulation training must be universally implemented and supported in these low-resource countries. Research into new diagnostic biomarkers and targeted therapies is urgently required, and coordinated international action and sustained investment is, quite frankly, non-negotiable. And for that, I have a few points of reference in the next slide for those who may wish to look at them, but therefore I end my presentation. Thank you.
Thank you so much, Dr. Caswell, for that wonderful presentation and for working with us on the technical issues. Appreciate the flexibility. So at this point, we'll conclude this session. We're sort of over time, and the next session 11, has already started. So we'll skip the questions. I want to thank all of our wonderful speakers for teaching and updating us on the health systems, quality of care, and equity for women and children in LMICs. I also want to give an immense thank you to all of you, our online audience members, for your attendance and your engagement in the chat, which is wonderful. I want to encourage everyone to visit the GSA website, sign the World Sepsis Declaration if you have not done so already, follow the GSA on the various social media sites, including Facebook, Instagram, LinkedIn, and TikTok. And thank you again to our wonderful sponsors. From me in Houston, Texas, I bid all of you good night, good day, and good morning. Thank you so much.